We got it. All right, I have no financial or other disclosures, other than it's not the fancy mouse with 8 buttons. So depression has a lifetime prevalence of about 15% in developed countries. The World Health Organization ranks major depressive disorder as the 4th leading cause of disability worldwide. And as far as surgical patients are concerned, in multiple studies, depression has been shown as an independent risk factor for worse surgical outcomes. And that includes increased morbidity and mortality in cardiac surgery patients, delayed wound healing, increased wound infections, increase in perceived pain, and increased length of stay in major abdominal surgical patients. As far as depression in bariatric patients, in an epidemiologic study of over 40,000 patients, people with a BMI of over 40 were about 5 times more likely to have experienced a major depressive episode within the last year. And between 21 and 61% of weight loss surgery candidates suffer from some psychiatric disease. The majority of studies looking at this in bariatric surgery patients find that the depression rates after bariatric surgery actually improve, and those are sustained for 2 years. Post-op depression is a predictor of less weight loss or less successful surgery. And it has also been shown that preoperative psychiatric evaluation can decrease postoperative depression. So despite the majority of bariatric surgery patients improving as far as their rates of depression after surgery, the elephant in the literature is that there's a small subset of bariatric surgery patients that are at increased risk of suicide and self-harm. There's a recent meta-analysis that found that post-operatively, bariatric surgery patients have a higher rate of suicide and self-harm compared to the general population, as well as compared to non-bariatric abdominal surgical patients. There's multiple reasons this may be the case. Some factors that have been found are preoperative depression, a lack of preoperative psychiatric evaluation, a lack of post-op follow-up, and there are some physiologic changes that could be contributing, such as a decreased ghrelin hormone level, alteration in their pharmacokinetics of antidepressants, and alteration of alcohol metabolism. And the absolute risk of suicide in bariatric surgery patients is very low. So ultimately, the decrease in obesity-related comorbidities relates to an overall decrease in mortality of 24%. We used a patient-reported outcomes measurement information system, which has validated question banks for our study. The PROMIS T-score metric uses a scale with 50 set as the mean of the general population. So a change in a score of 10 points is 1 standard deviation away from the general population. For depression specifically, worse depression is indicated with higher T-scores. So mild depression is a T-score of 55, moderate is 60, severe depression would be 70. And then conversely, when you're looking at positive outcomes and improved satisfaction with quality of life, those are higher T-scores. So a higher T-score in the satisfaction with social role survey means that they had greater satisfaction with their quality of life related to social roles. We evaluated depression and satisfaction with social roles before and after their bariatric surgery, and then we looked at persistence in those changes over a 1-year period. We also examined the differential effects of different procedures, specifically the sleeve gastrectomy and gastric bypass. We performed a retrospective analysis of prospectively collected PROMIS data in 594 bariatric surgery patients between 2013 and 2019. PROMIS depression and satisfaction with social roles T-scores were obtained preoperatively and then 6 and 12 months postoperatively, and T-tests were used to compare changes from baseline. The majority of our patients underwent Roux-en-Y gastric bypass, and this is a representation of the T-score means at baseline and then 6 months post-op and 12 months post-op. Looking at the two procedure types for depression, they both started out with a baseline similar to what would qualify as mild depression and similar to each other. And then both procedure groups improved at 6 months and 12 months postoperatively to about the mean of the general population. As far as satisfaction with social roles, they also started out with similar baselines, 1 standard deviation below the general population, and those improved to actually slightly above what you would expect in the general population, and a little bit more improvement in the gastric bypass group. And then just looking at these results graphically, the gastric bypass group is on the left and in red, and then the sleeve gastrectomy is on the right and in blue. So the baseline 6 months post-op and 12 months post-op are shown, and this just shows that their depression rates decreased and were sustained after 1 year. This is satisfaction with social roles with the same layout. So you see that the increase in T-score represents an increase in quality of life related to social roles, and that was also sustained at 1 year. Limitations of our study is that our data came from a single bariatric surgery center, and we have a very thorough preoperative screening process, including pre-op psychiatric evaluation. So this may not be applicable to all bariatric patients. And then this is also only showing 1 year of data. So some studies have shown that depression rates can change after 2 years. So we'll continue following these patients and see if the rates change. In conclusion, utilizing validated patient-reported outcomes, bariatric surgery patients demonstrated significant post-op improvement in both of our quality of life measures, and this was sustained for 1 year after surgery. And psychiatric evaluation of pre- and post-op bariatric patients is recommended by multiple bariatric surgery societies. And I would like to thank our Utah medical group and bariatric surgery group, as well as specifically Dr. Morrow and the SAGES committee for the opportunity to present today. I'll take any questions.